Week 12, we just meet to like just go over the results and everything. So really, you take HESI's during week 11. So really, we're halfway through the term. So just be watching your time, the things that you might need to adjust, delete, rearrange. So just make sure you're looking at everything, especially if you're taking more than one class. Make sure that you're looking at your schedules. You know, you have some you all have clinical, some don't. So just be looking at everything so that you can, refresh your schedule if you need to. Yes, Miss Tyler.
So I had a question about one of the assignments that you said we would have to do. I was listening to week one recording, and you were saying that we would be like split in groups,
That
and there
wasn't
was
this
some.
class. That
Oh,
was the
okay,
other class,
okay.
yes. Your Canvas aligns everything. Everything that's in your modules are there. Yes, I mentioned it last week, trying to put y'all in groups. No, not it's that's a different class. Yeah. So everything, there's no mystery, everything that's in your modules. So we are in week 5. And so yes, if you take a class, which class is it? That's leadership. In week 10, you have to do a presentation. So only thing you all have left for this course, we're week 5 now. So we'll finish up our content for exam 2, which is next week. And then we'll go back and look at last week content as well. So we have unit exam 2, which is next week. Then we meet for week 7 and 8, and we go over content 7, 8, and 9, and then you take that last exam in week 10. There is not a group project. I misspoke. That's another class. That's leadership. So, but the thing about week 10, having an exam in week 10, you all, if you have more than one class, that's the week. That's usually that third week and the 10th week is where a lot of those classes, those exam falls in the same week. Well, we know all HESIs fall in week 11, but usually unit exam 3 for a lot of classes, they do fall in week 10. I don't know if you even take another class, but just make sure that you're looking at that so that you can divide your time equally so that you can spend, the time that you need with your content. So again, there is no group project for this class. Your modules, it aligns everything. They're the adaptive quizzes, you have your unit exams, and then you have your HESI. Yes, that PowerPoint may have had that in there for a class that we do have a group assignment for. All right, so we'll finish up the content for unit exam 2, but then we'll actually go back from last week's 2 just to recapture that. But we'll go ahead and do week 5. And also make sure that you're going back and reviewing for all of your classes, reviewing content from week 1 up until, week 10, because the HESI, the NCLEX is all inclusive. Even though your unit exam may not have hit on you might have had one question or a few questions about a concept. Remember that NCLEX and that HESI, you never know what's going to show up on there. So make sure that you're just reviewing all of your content. It's just a continuous process. Just like when you go to clinical, your patients, they may have hypertension, but they may also be elderly. They may also, have an acute change. So you just never know. So just make sure that you're reviewing that content continuously. All right, here. Again, make sure that your name appears as it appears on the roster. If you have to step away from the camera, please put a message in the chat and we will move forward here. Let's look at our content here. I'm going to share my screen. My little mouse is doing something. All right. Sunshine. Okay. So we added this HESI highlight slide in here, you all. Move this over here. So with like I said, keeping in mind well, providing the best care you can for your clients, taking that NCLEX, that HESI, passing the unit exams. Just make sure that you are, in addition to your required readings, pull out your NCLEX book, look up a topic and look at those NCLEX questions. Read the rationales for the correct answer as well as the incorrect answer, because both ways you can validate and gain understanding. So just do that, on your downtime. Yes, I know you don't have downtime, but just commit to at least looking at a few of those questions every week. If it's nothing but 5 questions every week, but commit to reading the question, the answer choices, and the rationales for the correct and the incorrect answer. And that'll just continue to build and strengthen your foundation with the different concepts. So here we have focus on the concepts in your reading in the class discussion will help you prepare for the HESI exam. Psychosocial changes of aging, which transitions of aging and loss, illness, death of loved ones, loss of a home, loss of professional roles, loss of identity, loss of independence. Just think about, a person that's worked, that's done whatever job for 30 or 40 years, and then all of a sudden, they're retired. It's like, okay, well, what it is that person, do it all that time. Most people, right off, they initially, they do all these things that's on their bucket list, but then eventually they start to experience that identity loss. Like, okay, now what do I do now? After a year or two, what do I do with all this time? And so having them to discuss and think it through and come up with other activities, they may come up with new hobbies. That is real important, because that transitioning of aging, if we live long enough, we will experience that as well. And you wouldn't thought loss of a professional role. Well, I've been, you're ready to retire and just give up all of this, but it is really a loss because you've identified with being that person and doing those things for so long. And outside of your family, you spend just as much time, sometimes more time, in your professional role as well as with your loved ones. So we do have grief and bereavement as well. That's a part of life. Um, I don't know anyone that's really comfortable with it, but it is a part of life. And then we'll talk about also Kubler-Ross, those stages of grief, self-perception, and you need to know the stages in order, so make sure you know that. Self-perception and body image. We start to change, the lines, the movements and everything. And sometimes that is an issue of concern for people. So how do we talk through, and what does those conversations, those therapeutic conversations sound like? Do we ask closed-ended questions? Do we ask open-ended questions? Do we allow the client to tell us how they feel? And then do we validate their feelings? Because those things that they say, those things are real. We want to validate their feelings. We allow them to speak. Eric Erickson, generosity versus stagnation, integrity versus despair. Like, you don't really think about it until, that loss of that professional role or that loss of that loved one occurs. Changes in reproductive system and sexuality. Many older adults remain sexually active and are interested in intimate relationships. Sexual assessment should be obtained in acute care settings and long-term care facilities. So if a person is experiencing the same signs and symptoms as of or some of the same signs and symptoms, even if they were younger, of sexually transmitted diseases or some type of abnormality, we still do those assessments because there could be problems. There could be some infection or something like that that's going on. Age-related changes in reproductive systems are related to hormonal and nervous system control for both men and women. So changes in women, ovarian function decreases, vaginal membranes atrophy and become fragile and dry, causing discomfort with sexual activity. What do those conversations sound like? What interventions are there? Low estrogen levels in menopause can cause heart changes. This is heart month. I think Friday is they're bringing awareness to women in heart problems, heart disease. And so who would have thought that low estrogen levels would directly affect someone's heart? So that's what we're doing, that prevented, that teaching, having those conversations about, what is your blood pressure? Have you been checking your blood pressure? And in addition to that, it also causes those bones to be soft and could put that person at risk for osteoporosis. So we do want to be thinking about the environment, making sure that they have well lights, with this well, the environments are well lit, making sure that to decrease the chances of someone stumbling and falling, because if they actually do have osteoporosis where those bones are soft and the least little stumble, a bump of a toe or fall, that can shatter those bones. And we know those processes are, the healing processes could be long if someone has osteoporosis. So in men, changing that, testosterone production decreases, erectile dysfunction is common, prostate enlargement. We do know in men and women, they both do have those preventative exams, like the prostate exam, the mammograms, and things like that. So we do want to encourage the participants, the patients, the residents to still get those procedures done, even if they are in long-term care facilities. Those people, those residents, they still see the dentist. They still, the podiatrist still comes in. They still get their mammograms. So we do want to still talk about those preventative things. That is still part them of us helping to provide the best care for our clients. So this slide just shows our learning objectives. And we do have some, I know you all have seen this. Hopefully you've got a chance to go through these slides, and this is like a second or third time reviewing the content. But nevertheless, we will go through them. Family dynamics, you have the interrelationships between and among individual family members, whether positive or negative. Family dynamics change who we are and how we view the world outside of the family. Sexuality is defined by the WHO as a central aspect of being human throughout life, which encompasses sex, gender identities, roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. So this person's still living, sexuality is still part of that person. Self-esteem, how does this person see themselves now? They may have never worn glasses, and then all of a sudden they realize their vision has changed. They're needing glasses. They may be experiencing hearing loss. They may need a hearing aid, or they may have to have things in the environment to be adjusted. For example, large print. Next time you go to your clinicals, if you're in a long-term care facility or if you all are doing home health, observe the environment. See if you see any of those adaptive things that, so that the client, if they have a vision problem, is everything in regular print, or do they have large print, or things where they can reach? Pay attention to how the volume of the TV is in the room. Is it loud? Are they asking you to repeat things? Do they often say that you're mumbling, that everybody's just mumbling, but in fact, they might have a hearing problem? It could be that the ear is just packed with a large amount of wax and it may just need to be cleaned, but it also might be that they actually have that hearing loss, and that they may need that assistive device, a hearing aid. So if a person is experiencing any of that hearing loss, they may even lose control of their bowel or bladder. Just think about how that would make a person feel. They may feel a sense of powerlessness, loss of control. And so we do want to always establish those therapeutic relationships early, and so that they can express, and we allow them to, tell us how they feel, because their feelings are valid. Allow them to talk it through. So we have a scenario here. It says Mrs. Jackson is 82 years old. Her husband died 2 years ago, and she had a mastectomy after breast cancer. She tells the nurse, "I don't recognize myself anymore. I used to be a happily married woman. I was attractive, and I had a comfortable house and good friends. Now I feel like I've lost control. I look in the mirror and I don't recognize myself." So these things that Mrs. Jackson is stating, these are real to her. So we allow them to express themselves. We want to ask those open-ended questions. And sometimes, remember, we said silence is therapeutic. Just being there and knowing that, letting them know that we are there for them. But we can, reinforce, encourage their self-esteem, and then see if there are any alternatives. See if there are any, first of all, what they are exhibiting, is it signs of depression? And if it is, this person might need to go back in and be seen by their healthcare provider. So let's look at these signs of depression. Changes in mood, energy, restlessness, lack of concentration. You need to know these. Difficulty carrying out daily tasks, eating or sleeping too much or little, or losing or gaining weight. So it's the opposite. Not enough, and then it's just overeating, under eating, too much sleep, or not enough sleep. Increase in worry, excessive alcohol or drug use, sadness and hopelessness, avoiding eye contact. When we said making eye contact is therapeutic, but avoiding it could be a sign of depression. The person crying, if they're having suicidal ideations, giving away belongings, and them stating, no one will miss me when I die. This is not an all-inclusive list, but make sure that you understand that these are some signs and symptoms of a person that might be exhibiting depression. And again, it could be directly related to that loss of that role. You know, they're retired. After that 2 or 3 years go by, it's like, okay, what I do with all this time? They've identified for so many years as being whatever it was that they were doing professionally. And now, what do they do with all their time? So, case study, let's look for the key concepts. Okay, I'm going to pause here and let you all read through this one. Give you about 2 minutes to read through. Okay, so think about, list in the chat if this person has any signs and symptoms of depression. So I'll go back to this one. Anything in there that indicates that this gentleman may have signs and symptoms of depression. So list those things that you identified. I'll give you another minute to place those in the chat. Okay, and we're gonna check them. The things that you're saying. Let's stop sharing here. Okay. Seems that not eating, not hungry anymore, difficulty sleeping. Yes, good. Let's go back. So as you're reading through the scenario, remember the main concept is depression. So as you're reading, pull out all those things that you know about that are signs and symptoms and even statements that people would make. Okay. So this older adult is likely experiencing depression and may be contemplating suicide. So we need to be assertive and ask directly, because assertive remember, is being honest, and it's not, breaking the rules, is not demeaning, but ask directly. Do you feel like hurting yourself? Because let me see, what was his statement that he made? What's the use? I have nothing to live for. So you want to validate their feelings, because that's what he said. But then ask, do you feel like hurting yourself? What essential information should the nurse obtain? If yes, ask, do they have a plan? Is a weapon available? Do you have a weapon in the home? I mean, just ask, do they have a plan? And then, of course, we want to be present. Their phone numbers, depending on your state, that you can call. For example, if you're at the person's home, if you're over the phone, there are certain resources that you can call. But if you're in a facility, usually you just go to whatever their policy and procedure is. Anxiety is that uneasy feeling causing vague or unidentified threat. It could be mild to moderate. It could be acute, like right now with less than 6 months, and then chronic greater than 6 months. Okay. And usually these are the signs and symptoms that someone would be experiencing. They'll have that fast heart rate, breathing fast. They can't gather their thoughts. They're nervous. they just feel overwhelmed. Okay. So we do want to encourage our older adults to verbalize their thoughts and feelings. Ask those open-ended questions. Remain silent, be present, be there. Don't just dismiss their fears by saying, you don't have anything to worry about. Remember, that's negative communication. That impedes or stops communication when we make comments like that. We want to reduce excessive stimulation. We want to close the door, make sure that we're in that private setting. Like right here, if it's crowded and there's no background noise, you might want to have this patient to go into a different room. They have sitting rooms, might want to go back to their room, but make sure that the setting doesn't have all that excessive stimulation. Because a person might say, well, I can't even really think straight because I hear all this noise. If you're in the hospital settings, it just make sure that the alarms are attended to, because alarms they're beeping and going off, and that in itself can distort or overstimulate the person. So provide distraction or diversion activity groups. So we want to see if this person, what stress relief techniques do you use? Do you attend group activities? This is important. Providing that diversion. And you might have to assist them with looking at their calendar, deciding, especially if they're in a facility. Mostly all facilities have all of them have some type of interactions. Even in the hospitals, the thing that I saw not too long ago was pet therapy, and it fell under like art. I forget what the lady said her title was, but it was a gentleman and a lady. It was pet therapy, which wasn't new. It was where you could color and draw. This is in the hospital setting. And then what was the other thing? Oh, music. The person played, it wasn't a guitar, it was a different instrument, but they came around and that was what they did. So I said all that to say that there are all different types of activities, because one person, we all don't like the same, things. So they had a variety of things, distractions or activities for the people to participate in. Even in a long-term care facility, they have their big calendars up and have all their activities planned, but they also have alternate activities, because everyone might not be interested in the main activity that they actually have. And they want to teach, reinforce those coping mechanisms. I think I saw a message in the chat. Okay. This slide just showing the different types of stress, but it's very important to know those signs and symptoms, making sure that you allow that person to voice their concerns. We want to encourage social interaction and participation in social gatherings. We want to provide time to assist. And then when a person is experiencing that loss, loss of role, loss, with whether or not it's professional or they're feeling an anxiety, some distraction techniques can be, assisting that client with, doing their makeup, especially if, they're one that wore makeup, or styling their hair, or any other personal care that client is used to. But we want to assist them in maintaining that they have that control of, what's going on with them. And that in itself will promote self-esteem. We do want to assess the potential for self-destructive behaviors or suicide. We said that. Take seriously any verbalizations of the wish to harm themselves or to attempt suicide. Okay. And if therapeutic responses includes validating the client's feelings and inviting them to express whatever it is that they're feeling. And then we want to support the client's self-concept and their self-esteem. And a lot of times people will reminisce. They'll look back at the things that have happened in the past, and it's okay for them to discuss those past experiences. That stimulates memory, and it also will improve their mood. Allowing that client to reminisce and talk about the things of the past. And then, but we still want to bring them toward the present, and then see if they have make some new goals. And then those goals, make sure that they're attainable, because then that in itself will increase that client's self-esteem. Now, technology, with among older adults, some are tech savvy and some are not. That's even with some of us younger adults. So technology and computer use among older adults is increasing and has shown to have some benefits. One-on-one demonstrations, we want to take the time. If the person has a phone, to show them how to use some of those apps and different things that are on their phone. Allowing the client to practice, with the app, logging in and logging out and doing the scroll. And so the new thing, my mom, a stylist, that was something new for her over the last couple of months, learning what a stylist was. She was like, I'm tired of it, using my finger to scroll up the phone. So the stylist, but giving her the time to figure out what a stylist was and to use it. Plus, she has limited mobility in her hands. So allowing that client to practice will enhance that client's self-esteem. It will increase their sense of productivity. It will improve their social interaction, because she didn't realize touching those little with the little hearts and all that, little the thumbs up. She didn't realize that was actually giving a response from her. So we had to, teach her some, give her some instructions. Say, hey, when you touch these little things, it's telling people, whatever, whatever. So, but that in itself, it improves her social interaction, because now, if someone, a friend or a relative posts something, she's making that phone call to follow up with that family member. And that in itself will improve mental stimulation. It seems minimum to us because, we're used to it, but the aging population, they may or may not be tech savvy. So doesn't mean that they can't learn, just taking the time to show them those things. And then if they are in a long-term care facility, even if they're at home, for the most part, assigning that consistent caregiver to that, if possible. We do know that people have to take days off, and that will help develop that trusting relationship. So whenever possible, assign care to a consistent caregiver. This assists with developing that trusting relationship. The older adult should have access to familiar personal belongings, such as their pictures and blankets, even their purses. I don't know if you all have paid some attention in the long-term care facilities. People still have their purses. Most of them have, if they're going to be there long term, they have pictures of family members, and they may even have some of their jewelry box, different, personal belongings in their space. This provides comfort, and then it helps a person to keep in contact with reality. And they still feel like a person. So as I mentioned earlier too, the inability to control bodily functions, and also those limited range of motion. I don't know if you ever had something wrong with your leg, your arm, or where you couldn't have full mobility. So just think about that. You could have, been able to wash your face, but now because of whatever the osteoarthritis or rheumatoid arthritis or arm fracture, that person has limited mobility to wash their face, to care for their body. Just think about how that would make a person feel. So providing that assistance as deemed by that care plan is really, really important. It's not that person's not wanting to do for themselves, but they more than likely have some type of bodily function, some type of limited mobility. That's why they're needing that assistance. And some people, even, there's degrees of it. Some just need someone to be there just in case. They may have like one person assistant assigned to them, but it's not because they need that person to do all of the tasks, but just in case they can't get themselves into the restroom to get the water, or they may need some assistance with cleaning out the glasses because their hands, they have that limited mobility with their joints. Okay. Any questions so far? No, we just went over those slides. I was just going back, just giving you an overview of it. So you saw the slides. I just go back over it.
Dr. Morton, for some reason my camera isn't showing.
You might need to log out and log back in.
So you can't see me?
Who's talking?
Turquoise. So you can't see me.
Oh no, I don't see. I see your name. You're right. I do not see you. Yeah. You might just need to log out and log back in. And I don't know how that works, but sometimes that's what it is. You out turning things off and back on. Sometimes it's all that needs to be done. So Log out and we'll see you in just a few seconds. Yes, I do see your name, but your space is blank. Yes. So any of those concepts that we have that we just went over, talk about aging, validating that person, making sure that they have that self-esteem, the things that we can do to let them get it all out, loss of bodily functions, excuse me, and all of that. Just make sure that we have that down. So here we go. Normal roles and relationships. Roles we play define us, change over time. The parents may have had 5 children. They're all grown. The grandchildren are grown. So over time, the roles that we play, it changes. And if you're, for example, the grandparents might have been taking the children to picking them up from school and taking them home. They had these things to do, but over time that's no longer needed. So what happens? That person might experience loss. And as you see in the pictures here, we have here an older individual, like looks like he's working in a store. It's like, okay, he's probably not working because he really needs some money, but just want that social interaction and he just needs something to do. So many people after that 3rd or 4th year of retirement where they actually have just retired and just haven't done anything other than things on their bucket list. They're like, oh my goodness, I'm stir crazy. I need something to do. Now they don't want to work hard. They just want to do some volunteering or something 1 or 2 days a week. And if the community centers, they have adult daycare centers, they have different programs and things that people can also, okay, I see you now, that they can participate in too. And then you may even think of something that will assist, have some type of program out there that if someone experiences loss and grief, that you may have a program that meets once a month. You may start a support group. And of course, we're talking about the elderly here, the older adult here, but it might be for, any person. So just think about, know you're going to be a nurse, but what else can you do besides provide that bedside care? What else can you create? What else can you put out there? Loss of health, of independence, caregiver, who, if the person have lost their spouse, who's going to come in and provide that care? So then there's discussion about a facility, whether or not it's temporarily for that rehab. That's scary. A person has been independent and then all of a sudden they can't provide the care that they need in that home. And you're talking about leaving the home and staying in a facility where they're gonna tell me everything to do when to get up, and all of these things, and you're on a schedule. That is scary. So, but those are conversations we allow the people to voice their concerns. Loss becomes more common the older we get. No, it doesn't mean that loss can't happen while we're younger, but it does become more common as a person gets older. So we do need to know the stages of Kubler-Ross's stages of grief. You need to know them. Denial, anger, bargaining, depression, and acceptance. I think we have some slides coming up where we can have some scenarios where you identify each. So you need to know the order of the Kubler-Ross stages of grief. Okay. All right. Okay. Here's the slide right here. So you probably will need about 4 minutes to read through and then just put 1, 2, 3, 4, 5. And on your paper, you can just jot down on your paper without looking ahead at the slide, you all. Read each scenario and then write down the stage that each scenario is exhibiting. So just jot it down on your paper and then we'll check it. Let me get my little timer here. All right, and we can go ahead and start. We'll give you a little time to read through it on your paper. Just jot down 1 through 5 and then list the stage of grief. Minute and 20 seconds. Jot it down on your paper. Which stage of grief is each example scenario exhibiting? Okay. Okay, so they've been married for 52 years, though the loss was devastating. He's regaining his sense of hope and making new friends. So that's acceptance. Okay, in the second scenario, the person is asking them to check the name again. They must have the wrong person. So that's denial. 6 months have passed. She tries to pretend that everything is normal, but she is deeply depressed. Think about those signs and symptoms in that previous slide that we talked about. What are those signs and symptoms of depression? And then in the next slide, she makes a large donation in hopes that she will get healed. Not the large donation in the just for making a donation to assist in the research of lung cancer, but it says that she will herself be healed. That is why we make the donation so that they can advance and find out more stuff, more information, so that we can have new treatments, better treatments, and things like that. But in this instance, is the way it's worded, this person is bargaining. If I'll do this, hopefully this will happen. And then how could he leave me like this? She asked the nurse angrily, and that is anger. Grief is a strong emotion. It is real. It is real. That it's nothing that we take lightly. Like I said, we allow the person to, voice how they're feeling, because that is real. Allow them to verbalize. And we want to be sure to use those therapeutic communication skills. We don't want to be aggressive. We don't want to be passive. We don't want to pass judgment. We want to be non-judgmental. We don't want to give false hope, false reassurance. Identify if there are any support systems out there, support groups, and they could be in, family members. We do want to encourage them to participate in activities. What things that you like to do? Is anything new that you are interested in learning? A new game, a new hobby, to prevent that social isolation. Stress and life events. Older adults suffering from numerous chronic and or acute conditions under greater stress. The loss of friends, family members, and a spouse can be highly stressful for anyone. I know this slide is talking about older adults, but that's just stressful for anyone. Changes in residence or financial status can also cause stress. Like the example we just talked about, the person had some type of injury or something that would cause them not to be able to provide care for themselves. And they live at home independently, but now they cannot provide care for themselves, and they're not safe to stay at home. They have to go into a facility, whether or not it's assisted living or long-term care. Just think about that. That could be stressful. Fight or flight, that initial reaction. Look at all the things that a person experiences. Which of the following are signs of stress? You can come off mute and tell me which of these are the signs of stress.
Increased blood pressure.
Okay.
Muscle pain and headaches.
Okay, exactly. Uh-oh. Sorry, y'all. Okay. That decreased urine production and increased frequency. High blood glucose levels. Those hormones in our bodies get to overproduction, and it causes this to do this and this to do that. And then in essence, we end up with muscle pain. It's like, how can stress cause someone to have a headache, muscle pain, and blood pressure to be elevated? But it does. It leads to a domino effect. So that is why validating that person's feelings and identifying resources, you know, that those things will help them to be able to talk through and figure out what are their next steps. Depression and alcohol abuse can look alike because both of them, for the most part, slows down things, even their responses. They may have memory loss. But the person, doesn't have any doesn't use alcohol, more than likely it's going to be depression. But if someone does have is using substances and are abusing them over time, it can cause bone density changes over time. And with that, they may have those altered sleep patterns. And just think about when you haven't slept well, you may can't think through, you may have foggy memory, you may be just don't feel good. And then in essence, it can lead to loss of balance, frequent falls and injuries, broken bones. Okay. So this is just showing, yoga, Tai Chi is a new thing, pickleball, all these different coping activities and things that people might be interested in that they might not have really thought about. So just having opening those conversations up about what is it we can do to help you cope with what's going on. If you're having to change residence, you're going into the long-term care facility for rehab, what can make your stay better? Are you able to visit, have outings while you're there? Do you want to let your family members know? And if so, do you want to encourage them to visit more often? Do you want your person of faith to come and visit you? Just like, what are some things? Let's identify some things to help you get through this, to cope. Okay, these are just coping mechanisms. So while you might not see all of these remember on your unit exams, remember you still need to know this information to provide the best care you can for your clients, your NCLEX, and you just never know. Just make sure that you know all of these. Okay. We said this initially, the need for sexual activity does not disappear with age. So sexually transmitted diseases are increasing in the population age 65 and older, and that does include HIV and AIDS. Older adults are more susceptible, and this is one reason is because they may not use protection or they're not focused on not getting pregnant, but so they might not use protection. So in the event that they come in contact with body fluids that are infected, then they in fact can. So if they're exhibiting signs and symptoms, don't think, oh, we don't need to test for STD. We still follow the same algorithm in doing our testing. Okay. All right. So the 72-year-old woman reports she is sexually active. It is most important for the nurse to follow up by asking which question. Okay. Tell me more about your sexual partners. Remember, we want to ask those open-ended questions. Have you tried artificial water-based lubricants? Are any medications having any drying effects? Do you need to use different positions? Which of these is the most important for the nurse to ask? Okay. Tell me more about those sexual partners. Because again, they're not worried about getting pregnant. So then they don't think that they need to use protection or find out the status of themselves and their sexual partner. So that would be the most important. And these are some questions we might ask, but test taking tip. If it says the most important or priority, when we read our answer choices, more than likely we could do all of those things, but it's asking you to select which one is most important or should be done first. Okay. Age-related changes in men, orgasms take longer and has shorter duration. Time between orgasms increases. Orgasms may not occur every time. Erectile dysfunction is the most common problem. Erectile dysfunction is defined as an inability to achieve or maintain an erection during the intercourse in more than 50% of the attempts. All right, so let's read through this scenario here. You read, I'll put myself on pause. We'll borrow it. You moment to. What information is significant? Okay. Hypertension, alcohol, and then it's been 3 years. So we do include information about the normal age-related changes and sexually transmitted diseases. But if he's taking medication for that, his high blood pressure, then sometimes that medication will have a direct effect on arousal. So so if we know that they have hypertension, what medications are you taking, and look at those side effects. He doesn't smoke, but like smoking, alcohol use, all those things do have an effect on it. Okay, here we go. We have his meds. And sometimes you may see that a patient blood pressure might be out of control because they're non-compliant with their antihypertensive medication. And that's a valid question. Hey, are you taking these medications? Ask those open-ended questions. Would you tell me more as to why you're not taking them? And then a lot of times, most of the time, if they're not, sometimes it's because they can't afford them, but a lot of times it's because of the effects that they're having in result to them taking them. They don't like the way they make them feel, or they may not have that arousal. And so that's a question. That's something you want to encourage them to follow with their healthcare provider, because there's so many medications out there, and that they can be changed to, because we don't want them to have that blood pressure so high that it's going to cause them to have a stroke or heart attack or anything. Common cause of changes in sexual well-being: cardiac problems, diabetes, COPD, weakness or paralysis as a result of a stroke, chronic depression, and incontinence. All of these things impact a person's sexual health. So address issues in private with open-ended questions, because anyone will feel uncomfortable discussing certain topics anyways. So just making sure that we have that privacy, because we want them to talk and tell us what's really going on so that we can seek out a solution, identify resources. Okay, let's test our knowledge. A 90-year-old client in a dementia care unit starts undressing during a meal in the dining room. What is the nurse's best response? And someone kind of come off mute and just tell me which one is the best response. So these are things that we can do, A, B, C, and D, but which one will be the best response?
D.
Okay. Redirect that client and provide that privacy. Yes. So hopefully, if we are attentive and watching what's going on with us, we will see them starting to undress, so we can quickly redirect that client. Okay. So remember your study time. You want to review those difficult materials, review the content, go back and look at last week's content, this week's content, and make sure that we're going over everything. Identify those concepts that you still struggle with. That's like, oh, I just can't get an understanding of that. So make sure that that you write those down, and that's what you spend more time with. Okay, let's go here. Almost time for our first break, but we keep going. Okay. Okay. Pain is not considered a normal part of aging. Pain is subjective. I don't know if you ever had anything to hurt on you, but pain is real, you all. It is subjective, and it's how that person feels. Whatever they're verbalizing, we do want to write down the verbal and the nonverbal cues. Pain is subjective and can vary from one person to the other. With this person in 201, they've had a hip surgery and they're up walking around. They're refusing their pain medications. Person in 202, they're ringing that call light. Is it time for my pain medication? But pain is subjective and it does vary from person to person. Asking patients about their pain will encourage them to report pain more quickly. So it can be difficult to determine the presence of pain in confused adults, though. But look for those nonverbal cues. And then a lot of times if they're confused, if you're asking about pain, that's something that's real, and they will respond appropriately about that. Yes. And they may even point to, where indicate where they're actually hurting it. But asking the patients about their pain would encourage them to report pain more quickly. Patients often internalize their pain experience. So by us asking about their pain prompts the patient to report the pain more readily. So we should be doing our pain assessments. And then that way we can report back and share with the healthcare provider, hey, they may need something for breakthrough pain because this is not holding them. But we do want to ask about the pain because that'll, because sometimes people don't want to tell you they're hurting. So we're asking about it. That will, I'm glad she asked because I'm sure hurting. So that will prompt that patient to tell us more readily about that pain, especially if you're seeing nonverbal cues. They're guarding, they're frowning, they're crying, they're moaning. With each move, go ahead and ask about it. Okay, so palliative, provocative, what makes the pain better or worse? And then we could ask these more focused questions once we figure out if they're in pain. Describe your pain. Does it stay in one place? Does it move? Does it travel? Does it spread? Point to where it is. Where does it go to? And then what is the intensity? Now this scale, 0 to 10, sometimes people can't follow it. But, you can reword it on a scale of 0 to 10 with, 0 being no pain and 10 being the worst pain, or, that would be the highest number that you could give it. What number would you give your pain? Describe your pain. Give your pain a name, and the name is a number. Where would you put your pain at right now? What is that severity? And is the pain constant, or does it go and come? Because sometimes that pain goes and comes, and sometimes it's constant. But pain is real, and prompting that person, asking that person about pain, that will more than likely prompt them to verbalize. Okay. This pain assessment, this is one that is used in someone that has advanced dementia. Because like I said, it is kind of hard sometimes to determine, even with those nonverbal cues, whether or not this person's in pain or not. Okay, so look at that body language. Is it relaxed? Are they tensed up? Do they have facial grimacing? And then we document, no facial grimacing. These are words and terms that we can use to also validate that we actually assess their pain by saying they don't have these things or they do have these things. No facial grimacing, no fist clenching, or facial grimacing, or fist are being clenched, knees pulled up. These are some terms and phrases that we can use to describe, what we're seeing. Not only in dementia, but if someone is nonverbal because of a different disease, chronic process, these are things that we can look at, and we would document that. Okay, so Rose lives in a secure unit for patients with dementia. She has episodes of anxiety and confusion and is sometimes aggressive with staff and roommates. Which of these interventions would be helpful when working with Rose? Okay, so come off mute and let me know. Which of these interventions would be helpful when working with Rose? Do we want to force her to reorientate reality when she gets confused? Do we want to provide structure?
Use familiar objects and provide a structured, stable environment.
Okay. What about those physical and chemical restraints? Do we want to use those? Mm-mm. We don't want to use physical and chemical restraints. Okay. So she's having episodes of anxiety and confusion. So it could be that, remember we said get that environment so that it's they're private, that it's not all that stimulation going on. So this person is having episodes of, trying to move this bar down, of anxiety. So if she's having episodes of it, she's not having it all the time. So what is going on at this moment? Does this person do they have loss of bowel and bladder? Is it that they need to be, changed, checked and changed? Perineal care needs to be given. Is it that they're hurting? Is it that there's too much stimulation that's going on? What is really going on? So we want to assess that environment as well. Okay, Mary moved into a nursing home 2 weeks ago. She believes the staff are stealing her belongings. She can't understand why people come in and out of her room all the time, taking her clothes, removing unfinished food. She was saving for later. Because think about it. We place the meal trays in. That food can't stay there. So if a person has dementia, they're thinking we're taking their food away. But if you were at home, you would put that food in the refrigerator, leftovers, and then taking their clothes. We had to take those, if they're in a facility, we're having to take those clothes out to be laundered. So they're thinking someone has dementia, maybe thinking that someone's taking their clothes. She started hoarding food and hiding her things because she's thinking someone's taken. How would you handle Mary's suspicion and those hoarding behaviors? Okay. So hoarding is real, and the reasons for it, it may vary, but we would need, and hoarding can be dangerous for the person, especially also if they have a roommate. So we need to be making sure, if it's those food items, if it looks like, if we see food, placed in the drawers, that can lead to rodents, bugs, and things like that. So we want to make sure that we're removing all of those things out. If we set up their tray and they had a spoon, fork, and the knife, make sure that all those things are on the tray, because that can lead to an unsafe environment. We do want to do interventions that foster trust, repeating ourselves if we have to, giving that explanation. Are you finished with your meal? We need to take the meal tray up so we can, dispose of the things that you didn't eat, so we can wash these dishes and get the next meal prepared at whatever time it is. So we want to simplify the environment. We might want to, like I said, turn down the background noise and things like that. Okay, so we want to stop and pause, and let's just do a 5-minute break. So we want to make sure that we get through all of our content, and I'm sure we'll have time left, and we'll just take the rest of it at the end. So let's see, what time is it? It's 9 o'clock. So let's return at 9:06. Remember, this recording will still play, so make sure your cameras are off and you are on mute. We'll see you at 9:06. Okay. Joe lives in a assisted living facility for older adults with dementia. He enjoys watching news and sports on TV and reading the newspaper. Lately, he has started wandering out of the apartment. He gets irritable and sometimes aggressive when staff ask him not to leave alone. What would you do to help Joe maintain as much independence as possible while keeping him safe? Okay, so medication should never be an intervention for wandering. That's a chemical restraint. An assessment for a risk of falls may be helpful in order to get a clearer sense of his mobility. And also, we don't want him to fall. So assessing that environment, identifying anything that's going to put him at risk for falling, making sure that he has, good fitting shoes that have those non-slip soles, making sure that the floors, if they're at home, they advise against those throw rugs. But if they have like those non-slip padding, that lessens the chance of someone sliding and falling on those rugs. Risk and benefit analysis of ambulation in the area of wandering. Now, a lot of facilities do have those closed units, and with those closed units, the amount of space, it's a decreased length of space to wander. So, and then some of them, I've even seen some facilities where the space that they can walk, they're just walking in a circle, so like it never ends, and so that decreases the chance of them wandering out of the facility, and being, harmed by being outside and not aware of their surroundings. So distraction to wander in a safe surrounding. That's, the whole notion of that round space with wandering is really you can't tell it's a circle, but it's really a circle. But the person just, keeps walking and the surroundings are safe. Education to his companion regarding wandering as a common symptom of dementia, making plans. So educating re-educating the family about, their condition, making plans for activities to keep him ambulating is an important consideration. Sometimes they just need that time to walk. Stop signs, simulated water design, strategically placed, Velcro net gates can all be barriers to keep a wanderer in. Joe can walk. Can you walk over here with me and help? So giving them something to do. A lot of times they just need something to do. Therapeutic communication involves using open-ended questions to gain more information from the client. It is client-centered and client-focused. Some examples are many people feel nervous before, while being in the hospital or before having a procedure done. What are your concerns? What concerns you most? That's an open-ended question. So you are validating what they might be experiencing, and then you're asking them to tell you more. Another example is, tell me what is making you have concerns or questions. Again, another open-ended question that hopefully we'll gain more information. And that way we can, that guides our next steps, our next intervention for that client. Because it could be that if they're having surgery or something, it could be that they didn't have all their questions answered. So we'll let their healthcare provider know, hey, this person, they have a few more questions they want to ask you about, the surgery. So we can get that person back in and talk to them. If a client is unable to verbalize because of a disease process, what interventions should be implemented? What do you think we need to do? The nurse. What do you think the nurse needs to do? Okay. Alternative methods of communication are needed. So that could be boards. It could be them having something to write on. I've even seen boards with that already have like pre-printed responses on there, like with most of our most common responses, like yes, no, pain. Like they'll have something that says pain, hungry, not feeling good. They'll have a board that's already pre-printed up with symbols or words already on there. And I've also seen like dry erase boards where people just write. But we need to have some type of alternative method so that person can communicate with us if they're unable to verbalize. Discuss examples of therapeutic nonverbal behavior that enhances communication. Speaking to a client at eye level, sitting if that client is sitting, that will get you at that eye level. Making eye contact. These nonverbal behaviors can put the client at ease, and it also can assist with that therapeutic connection. So that client will give you more information. Using gestures, written words, and visual aids can also, when given instruction, that also can help with that therapeutic communication. Using gestures, written words, calling that person by their name. Patient in room, instead of saying patient in room 201, Mr. John, or, whatever his name is, asking them what would they like to be called. Using touch cautiously, though, when communicating with a client who has dementia, because the patient may have difficulty understanding and interpreting what that touch actually means. So we want to use touch cautiously, but make sure that we're understanding, having been at eye level, sitting, making eye contact, that using gestures, and all of these things can help us with that therapeutic connection. What are some approaches to promote healthy self-perception? Okay, identifying the unique strengths of each person so that they can be drawn on when planning care in a non-judgmental manner. Everybody has strengths and all of us have weaknesses, but identifying those unique strengths, and then let's draw up on that. Let's focus on that. Being non-judgmental. If this person this is a strength, that's a strength. We want to encourage a positive outlook on aging while focused on retained abilities and support. That helps support that healthy self-concept. Hey, well, you may have some bladder spillage. Well, let's find a resource. Which of these dope briefs do you think fits better? Which ones do you like? Are you taking your medication? We do, of course, we're going through the things and making sure that if they're on any medications, do they have a urinary tract infection? Are those issues? It might be just that bladder wall has leaking. So if that's the case, what resources can we have to promote that person to have that healthy self-concept? There are different types of briefs. Which ones would you like? Okay. Open-ended questions elicit conversation. That helps propel so that we can gain more information. Do not dismiss the client's concerns. What they're saying is valid. Okay. So indicators of hearing loss, that person might say that people are always mumbling, that they're having difficulty hearing on the phone, difficulty hearing high-pitched voices, and difficulty hearing when there is background noise. And they may keep their television on high. Okay, true or false? In the chat, put a T or F. Shouting and using exaggerated mouth motions are effective communication techniques for a hearing impaired client and should be avoided. Let's see what you're saying. So should we be using shouting and exaggerated mouth movements? Let's see what you're saying. Actually, that raised voice, that distorts. I know y'all couldn't see me. That distorts the person's what you're actually saying. It makes it, for example, if you're saying, it's the sun is shining. If we say it louder, it may sound like something else. So it is actually shouting. It's actually a barrier, to communications, almost like you're being aggressive if you're shouting. So yes, that is false. Acute confusion, often called delirium, is characterized by disturbances in cognition, decreased attention span, memory, and perception. So acute is not chronic. So acute is something that's happening, like right now is new onset, and hopefully it resolves. So this is why we're saying it's reversible. We find out what's causing them to be have delirium and acute confusion, and it usually resolves. Something that comes to mind is urinary tract infections. That usually causes people mental status for them to be confused, to have that altered mental status. They may be saying things that they normally wouldn't say. They may be having behaviors that they normally wouldn't have. But once that, if it in fact is a urinary tract infection and it gets treated, that person returns back to normal, as we say. But dementia is a slow, insidious process that results in the progressive loss of cognitive function. It's lost, so it doesn't come back. Dementia is characterized by changes in memory, their judgment, even their language. Sometimes, if that dementia is so advanced, they may have a voice and they may speak, but some of the things they say, it's just a word salad. It may be sounds coming out, but it might not even sound like words. Their judgment, their language, mathematical calculation, just their reasoning, problem solving, all of those things will be altered because this person has loss of cognition. Cognitive impairment individuals sometimes becomes anxious, and so remaining calm, because sometimes it depends on if it's new onset, and sometimes they'll realize that they're not themselves. So just knowing that they're not themselves, they become anxious. So, but we as a nurse, we want to remain calm and giving the client clear directions, breaking those instructions and those directions down. We remain calm, provide that reality reorientation, give those clear directions, and that in itself will decrease the client's anxiety. Okay, we talked about Kubler-Ross. We've already had this slide, but make sure that you know the stages and then the order of them: denial, anger, bargaining, depression, and acceptance. And you all did really good on the example that we gave with the scenarios. Encourage the client to verbalize feelings of sadness or depression relating to the loss of a loved one. Again, ask those open-ended questions. Get what the things that they feel, those things are real. So we can identify whether or not they need additional resources. We talked about the person, if they were contemplating suicide, do they have a plan? Do they have a weapon? Talk it out, have them to tell you more. Discuss signs of depression a client may experience. We talked about that as well. Irritability, we talked about those appetite changes. You all did really good in that scenario. You identified the signs and symptoms. A person may experience digestive problems. They may have an upset stomach. Okay, and these are just a few signs of a person that is experiencing depression. Stress, finding out how the client copes with stress by asking how stress had been managed in the past. How long has it existed? Because sometimes they forget about those coping mechanisms and the recipe or the map that they use to work through whatever that stress will causing them stress. Sometimes they forget it. So asking them, hey, have you ever experienced this situation before? And if so, what did you do? What helped? What things you found that did not help? So identifying the things that did not help, going forward, we more than likely don't need to do those again. But nevertheless, seek that additional information from that client so that you can get clarification. Okay. So I went back through this week's, then last week's information. Are there any questions about any of those concepts? You all have done really well with the scenarios and everything. So again, make sure that you go back through this week's recording, your slides. Make sure that you're reading every slide piece by piece, making sure you're understanding it, the information that is there. Blueprint for the exam. Let me see if we got a blueprint. Let me look and see if we have one. Again, take the time to go through those slides. I know some of them have a lot of, and I like to go back and kind of like decrease the amount that's on one so that you can just take a little chunk at a time. But make sure you go back through those slides. The information is there with the scenarios. Make sure that you are able to apply. And you all did well with that. Like we asked about the stages of grief. You all were able to identify those scenarios correctly. Okay, let's see. Okay, I'm gonna post this. I'll send it to your mailbox, your Canvas mail also. And while we know you can attend all the exam reviews as the recordings are made available, make sure that you go back through them. Now with the math, make sure that you're not looking at the answer key before working it through. So the concepts are communication, the functional ability, health promotion, self-management. So those are the huge topics. But then under communicate, think about what we use to communicate: hearing, our vision, and our voices. What is that communication? What will stop communication and what will encourage communication? So think about ineffective and effective communication. Functional ability, think about the sensory and the cognitive changes. Okay, I will send this to your Canvas mail and let me know if you all get it. I'm going to send it. Just give me 1 minute here. And there are what about 7 of us? So there are several reviews if they're held. So at least, you know, even though we're saying the same thing, it may be stated differently. And that 5th time, oh, you know, it'll resonate with you. So just make sure that if you can attend them, make sure that you're at least going back through those reviews and your classroom recordings. Well, trying to put it in the Canvas here, you all.
Our test is next week.
Yes, and those are our main concepts. It doesn't seem like a lot, so don't take it lightly, you know, but just as long as you're able to apply. There we go, right there. Okay, it's attaching now. Y'all give me just a moment before you hit your Canvas mail. So it was last week's information and this week's information. I sent it to your Canvas mail, but I put it on the main announcement screen too. So that way you'll have it available in both places. Let me check in the chat and see if there are any other questions. So exam reviews, make sure that you go back through. I'll look and see what the postings is for the recordings. Make sure that you go back through our classroom recordings. Okay, you got it. Good. All right. So the next thing I'll look and see what our schedule is. And that is it. You all take care and we'll see you on next week. You're welcome. Make sure y'all go back through our recordings now. I'm looking for the schedule here.